Oh. That's it. Okay. All right, everyone. Come on, computer. Come on. Get your coffee and wake up. Wake up. Oh, there finally. Okay. Antibiotics. That's great. Okay. How is everyone? Nice to have a temperature in the double digits for a change, huh? I don't know about you, but I'm kind of digging that because last week walking to school was painful. But now I can do it and not have every step be painful. Yeah, we're liking this. We're liking this a lot. All right. Let's pray first. Lord, thank you for a little warmer weather, for snow that's melting. And thank you also that COVID cases are down. Deaths are now starting to come down. Hospitalizations, at least in Michigan, are way down. And Lord, we continue, the trend would continue down. The number of vaccines would continue to go up. Thank you for this time and for our students here in Jesus' name. Amen. So you probably heard we hit 500,000 cases, 500,000 deaths in this country. But whereas COVID cases are going down, deaths had pretty much flatlined. There's a 2-week delay between cases and deaths. When you looked at it, it was any day now, deaths are now starting to come down. So hopefully this is real and it is sustained. B117 has been detected in Michigan, was detected in near Detroit. It could be more widespread. Our sequencing is so spotty. Could be all over Michigan for all we know. Could be here at Spring Arbor. We don't know. So we know B117 is definitely more transmissible. It's not necessarily more deadly. So hopefully it just runs its course and then it runs into herd immunity. That's what I'm hoping for. I want to be optimistic. I'm trying to be optimistic. Really, I am. Really, I am. So, all right. So antibiotics. There we go. Okay, so we have the penicillins. What do these target? What do these target in the bacterium? What do these target? Louder, please. Someone said it. Louder. I heard someone say cell wall, kind of timidly. Can someone maybe say it with a bit more conviction? Cell wall. Thank you. The cell wall. Because they target the cell wall, they're only effective against growing bacteria. You have bacteria that are in some sort of stasis or stationary phase, these antibiotics will not be effective. They're only going to kill growing bacterial cells. So these are bactericidal. So there's different groups of penicillins. We talked about the so-called natural penicillins, penicillin G, penicillin V. Penicillin G is parenteral. Penicillin V is oral. Then there are your more broad spectrum, the amino penicillins. And that includes ampicillin. I discovered there is an oral preparation of ampicillin. I don't know why anyone would give this drug orally. It's horribly absorbed orally. I just don't know. It's typically given parenterally. Whereas amoxicillin is much better absorbed. Bless you. Oral. And these drugs, in general, are good for gram-positive cells. The coverage of gram-negatives is spotty. They don't hit anaerobes at all. And they're worthless against pseudomonads. And then, of course, because these attack the cell wall, you have an organism with no cell wall, like mycoplasma or chlamydia or something like that, they're not going to be effective at all. So do keep that in mind. Then from the aminopenicillins, you have the penicillinase resistant penicillins, or so-called antistaphylococcal. So Staphylococcus started making enzymes that degrade penicillins. These were designed to resist those enzymes, and this includes nafcillin and cloxacillin. Cloxacillin is not available in this country. Flucloxacillin is not available in this country. Oxacillin is. These are only effective against methicillin-sensitive Staph aureus. They're not effective against methicillin-resistant Staph aureus. And these have no coverage against gram-negatives. Gram-negatives, nope, 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 nope. Yes?
We just talked about
No, no. The drugs we covered last time that are specific for MRSA, vancomycin, ceftaroline, daptomycin, those will hit MRSA. None of these drugs will hit MRSA. Yes?
Are all the anti-staphylococcal
They are effective against methicillin-sensitive Staph aureus. Pretty much. Pretty much. So your natural penicillins, penicillin G, are still the drug of choice for neurosyphilis. They're not used for much of anything else these days. Really, they're not. Yes, neurosyphilis. Anybody remember which organism causes syphilis? Try to remember. Try. Pull the cobwebs back. Treponema pallidum. It's a spirochete. Remember the corkscrew-shaped doodads? That's Treponema pallidum. Penicillin G is still effective against Treponema pallidum. So you get intravenous penicillin G, not intramuscular, intravenous. All right, so those are your antistaphylococcal penicillins, and then you have another group of penicillins that are extended spectrum, but they're more they're anti-pseudomonal. They're designed to be active against Pseudomonas aeruginosa. And so this includes drugs like carbamazepine, spell that right, yeah, see already, carbamazepine, piperacillin, PIPDR. Piperacillin, carbamazepine, and then ticarcillin. This one never gets to any appreciable concentration in the blood. So it's only good for UTIs because it's excreted by the kidney. UTIs only. These do get to appreciable concentrations, so you can use them. Then you have your beta-lactamase inhibitors. Beta-lactamase inhibitors. Anyone want to take a gander as to what these are for? What are beta-lactamases? Penicillins have what chemical structure? The whole group is named after this chemical structure. Euler. I have a beta-lactam ring. So this whole group are called beta-lactam antibiotics. Beta-lactamase enzymes degrade the beta-lactam ring. They render the drug innocuous. So these are going to inhibit the beta-lactamases that bacteria make to degrade the beta-lactam antibiotics. So your penicillins, your cephalosporins, all together they are beta-lactams. Beta-lactamases are enzymes that degrade beta-lactams. When you put these together with these drugs, you now extend their spectrum because now the enzymes that the bacteria make to break them down are inhibited. That make sense? So, augmentin. Augmentin is amoxicillin plus clavulanic acid. Clavulanic acid is a beta-lactamase inhibitor. Amoxicillin is a beta-lactam antibiotic. Ampicillin plus sulbactam. That is a beta-lactamase inhibitor. That is a beta-lactam antibiotic. This is Unas. That is used for very nasty infections inside hospitals that are caused by Acinetobacter baumannii, which is the bane of burn units. The bane of burn units. And then you have piperacillin. Plus tazobactam. Piperacillin, beta-lactam, tazobactam is a beta-lactamase inhibitor. And that goes by the trade name Zosyn. You see the strategy here? So piperacillin very often is given with tazobactam. And that, therefore, if the pseudomonad makes an enzyme that potentially degrades piperacillin, that enzyme is inhibited. And so on and so forth. Yes.
So beta-lactase inhibitors, they're always combined with something.
Beta-lactam antibiotics are sometimes given on their own, but they can be given as a combination with a beta-lactamase inhibitor that extends their spectrum. So if you have an organism that makes beta-lactamase, you can give the beta-lactamase inhibitor with the beta-lactam antibiotic, penicillin, the cephalosporin, or whatever, and that extends its spectrum. So that's why augmentin is used for sinus infections, not amoxicillin. Because many of the organisms now that cause sinusitis make beta-lactamases that degrade amoxicillin. Anybody remember side effects? What are some of the side effects of penicillins? Patient comes in, gets a script. You're checking the patient out. What do you tell them to expect? Take it what? Take it with a probiotic. Yeah. Might be good advice. Oh, so if they'd expect GI disturbance? Would they expect that? For some, yeah. Most people take these not an issue. It's probably 2%. So you might say something like, this might upset your stomach. If it does, take it with food. Take it with a probiotic. Take it with lots of water. Take it with some crackers. Take it, whatever. In England, nurses there lean very heavily on ginger snaps. Oh, if this upsets your stomach, take it with some ginger snaps. Everybody there uses ginger to quiet their stomachs. Personally, I can't stand ginger snaps, but that was a big thing that the nurses, British nurses, always told patients, oh, take it with ginger snaps, because ginger is supposed to calm your stomach. Well, I have no idea if it does or not. But hey, you have good luck with ginger, pass that on to your patient. I, for one, can't stand the stuff. So that's just me. What else? Yes, Clarissa. Uncommon, pretty uncommon. And if they do have a headache, it's unlikely the antibiotic is the cause of it. There are some antibiotics that will cause headaches. Penicillins, not really. Now, you have hit upon something at high doses. Penicillins can lower the seizure threshold. So if you're prone to seizures, it's just lowered your seizure threshold at high doses. At regular doses, typically not, but what if you're prone to seizures in the first place? Then that might be an issue. So there is a seizure risk, upset stomach. What else? Allergies. Allergies. Turns out the number of people who say they're allergic to penicillin is mightily overestimated. If you send them to an allergist and have the allergist properly test them, turns out a good proportion of people aren't, who say they are, actually aren't. So the percentage of people with a penicillin allergy is probably vastly overestimated. Having said that, if they've had a previous allergic response to penicillin, you don't give them a penicillin. So allergies. And if they're the allergies with penicillins are type 2 hypersensitivities. Type 2 hypersensitivities. Victoria, do you remember anything about a type 2 hypersensitivity? Remember the mechanism of a type 2 hypersensitivity? Okay, let me help you. Okay, it binds the surface of a red blood cell. And then what happens next? Sydney's back there champing at the bit, so. Sorry? No, that's type 1. That's type 1. Sorry? No, the penicillin binds the surface of the red blood cell. It forms a complex with a protein on the surface of the red blood cell. And that combination is now new to the immune system. So the immune system recognizes that as foreign. And it produces antibodies against it, and it causes complement-mediated lysis of red blood cells. The red blood cells, the debris, the flotsam and the jetsam of the red blood cell destruction get caught in small capillaries, and you get a rash. And you get the little flecky bruising and what have you. And it can happen in the ears. That's one place sometimes where it happens. But yeah, that's a allergy you can get from penicillin. Antistaphylococcal penicillins can cause phlebitis. Andrea, what's phlebitis? That's actually pretty good. Yeah, it's inflammation of a vein. And it's that the IVs can cause phlebitis. Yeah. Yeah. So it's inflammation of a vein, typically caused by a clot or by trauma to the vein, like with an IV port. Now, what's the difference between phlebitis and DVT? You know what DVT is? Good. Okay. Emily? Yeah, and DVTs they can break off, can't they? With phlebitis, the risk of the clot breaking off and traveling is extremely low. Whereas with DVT, deep vein thrombosis, it's actually pretty high. The other issue with penicillins tend to have short half-lives. You have to dose them often. All right, questions about the penicillins before we move onward and upward? Okay, good. Next are the cephalosporins. There's first generation, second generation, third generation, fourth generation, and now fifth generation. So the cephalosporins are also beta-lactams. So let's talk about the first generation cephalosporins. So there's really only two main first generation cephalosporins. Well, three actually. So there's a cephalexin. That one's oral. There's cefadroxil. That one's oral. Then there is cefazolin. And lots of websites say this comes as oral and parenteral. I actually checked that with my friendly neighborhood pharmacist. He said, yeah, the oral got discontinued. It's not being made anymore. You might find some out there, but it's not being made. So really, this is only available parenterally. First generation cephalosporins get predominantly gram-positive bacteria. They have a lot of the same coverage as the anti-staphylococcal penicillins, but they don't cause phlebitis. They don't cover MRSA. They don't cover pseudomonads. They don't cover anaerobes. These are used for surgical prophylaxis if someone's having bowel surgery of some sort. Then there's a second generation. Second generation, you have less coverage of gram positives, little more coverage of gram negatives. So these are now good for a lot of your gram negative rods, at least some of them. Some are gram-negative rods, and then they're also effective against many species of Haemophilus. And they used to be effective against Neisseria, but not anymore. There is a group of these that are effective against anaerobes, the so-called cephamycins. Those are good against anaerobes. But the main ones don't, but the cephamycins do. You don't have any coverage against MRSA or Pseudomonas. These drugs will produce a disulfiram reaction if they're taken with alcohol. So disulfiram is given to alcoholics. Disulfiram, if they take it and then they drink it, disulfiram inhibits the enzymes that process the alcohol. So it causes them to get violently sick and they upchuck. And therefore they equate behaviorally drinking with getting violently ill. So they stop drinking. Does it work? Not really, because if people get sick, they just stop taking the disulfiram. But if you take alcohol with these, you get a disulfiram reaction. Translation, you puke your guts out. So patient comes in, they get a script for one of these, you're going to tell them, lay off the sauce. Or something like that. Yeah.
Did you say they're also effective for gram-positive bacteria as well?
They have less coverage for gram-positives. They have some gram-positive coverage. They'll hit some streptococci, some staphylococci. By no means all. Also, several of these will interfere with vitamin K production, or rather vitamin K usage, and they can prolong bleeding. This is usually minor, but if someone's already on a blood thinner, it can make their bleeding risk a lot worse. Yeah, Abby? No, not production. We don't make vitamin K. We get it from our diet, vitamin K utilization. Utilization. I said production. I tried to correct myself and I didn't quite get there in time, did I? These also do not cross the blood-brain barrier. You can't really use them for meningitis. So these include cefaclor, cefaclor used to be called C-chlor, but I think it's completely in generic now. I don't think the trade name cefaclor is available anymore. I think it's all generic if I'm remembering that properly. And then there is the cefprozil. These both are oral. These are the only second generation cephalosporins that are oral. Then you have the ones that are good for anaerobes. And that would be cefotetan. cefotetan, and cefoxitin. Those are good for anaerobes, those you give parenterally. There's another one called cefmethazole. That one's been discontinued. You find it in drug lists, you find it in books, but you can't find it on anybody's shelf because the company stopped making it. So you'll never use it, don't worry about it. All right, third generation. These are the ones across the blood-brain barrier and are used to treat meningitis. These are now, again, as you go down, remember, you get less and less gram-positive coverage, more gram-negative coverage. So these are going to be usually very active against gram-negatives and not nearly as active against gram-positives. So these are very good against gram-negative rods. They're very good against your Neisseria. In fact, they're the drug of choice against Neisseria. Also good against Streptococcus, in particular, Streptococcus pneumoniae. They have the same side effects as the second generations. So the big gun here is ceftriaxone. That one is parenteral. Very good drug, very effective. The stand-in drug is cefotaxime. Ceftriaxone, you never give to infants. Causes biliary sludging. Causes biliary sludging, and you'll have big trouble with bilirubin levels and what have you. Never use it in babies. Everyone else, you can use it. In babies, you use cefotaxime instead. The other one of these that crosses the blood-brain barrier is ceftazidime. Ceftazidime. Ceftazidime is a very useful drug in this group because this is a specialty drug against Pseudomonas. This is your anti-Pseudomonas specialty drug. That's important, especially if you work in burn units. Pseudomonas aeruginosa is a scourge of burn units. So those three drugs are all parenteral. There's two oral. Third generations are ceftonir. That's oral, and so is cefixime. Oral. These are all parenteral. Okay, fourth generation. Fourth generation, there's just one drug. Glory, hallelujah. That's cefepime. Cefepime. So cefepime is effective against your gram-negative rods. It's effective against Pseudomonas. So we say this one's very specialized for your gram negatives. Has some activity against and Acinetobacter. And some activity against methicillin sensitive Staph aureus. So this is pretty broad spectrum. So this gets used for really nasty infections. So if you have, say, a cancer patient, a lot of cancer drugs knock down white counts pretty precipitously. So febrile neutropenia, you'd use this drug. If you have postoperative meningitis, you'd use this drug. Other types of nosocomial infections, you'd use this drug. Pretty good for that. We talked about the 5th generation Taflaro or ceftaroline. That one is designed specifically against MRSA. Again, it's a very new drug. So you use that one last in your list. You just got, there's less information. Yeah, it works against MRSA and not much else. Oh, that's not true. It's also effective against methicillin sensitive, but it's overkill. The overkill to use that against methicillin sensitive Staph aureus. They're better drugs, cheaper drugs too. Drugs that we know a lot more about. So, yeah. Ceftaroline. All right. Other group of the beta-lactams, that includes the very broad spectrum carbapenems. 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 So this includes the granddaddy of the group, imipenem. We said this about imipenem last time. Imipenem is converted by an enzyme in the kidney into a toxic metabolite that damages the kidneys. So you have to give this with an inhibitor of that dihydropeptidase in the kidney, and that is called cytostatin. You always give this as a combo. Always, 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 always. If you don't, you will have a patient whose kidneys have been fried, and it'll be your fault. So imipenem, that's the granddaddy of this group. Then there is doripenem. And meropenem. And ertapenem. And then finally, finally, that's it. Okay. These, as we said before, very broad spectrum. Very broad spectrum. If you have drugs that don't hit certain bacteria, these may very well hit them. So if you have, for example, someone whose appendix goes kaboom, and you have peritonitis, there was a paper that came out in the Journal of Internal Medicine showed in 70% of cases of appendicitis, you can actually just give antibiotics. You need to give surgery. Now, would it relapse? Yeah, but doing that rather than putting them under the knife. So now that strategy is probably going to be done quite a bit more. If you have an infected appendix, it is a mixed infection. You want something broad spectrum. These are the drugs you turn to. These drugs have broad spectrum against both gram-positive and gram-negative bacteria. Also, they have low cross-reactivity with penicillin allergies. Low cross-reactivity with penicillin allergies. Yes, great.
So these, we're not talking about cephalosporins anymore. These are completely different.
These are completely different.
Okay.
The penicillins, cephalosporins, I didn't change the slide.
So these aren't penicillins either.
They're another group, right?
Okay.
Carbapenems. This one is narrower spectrum than these other three. This one has no activity against Pseudomonas. And then finally, you have the monobacteriums. There's just one drug in this group, is Trina. This particular drug has the same activity pretty much as ceftazidime. Astranum has no cross-reactivity with penicillin allergy, none. And this comes as an inhaled form that's used for people with cystic fibrosis, because people with cystic fibrosis very commonly get Pseudomonas bronchiopneumonia, which is my guess is pretty hard to treat. So there's an inhaled form of this drug. It's called Casten. Casten. I think that's how you spell it. That is used a lot in patients with cystic fibrosis. And those are the beta-lactam antibiotics. Remember, it's cell wall, they're bactericidal, they're by and large pretty well tolerated. They have their caveats. They may upset your stomach, they may cause allergies, but these don't cross-react very well with those allergies. And your penicillins at high doses can lower the seizure threshold. That is pretty much all she wrote. Okay, questions on the beta-lactams? Yeah, Eddie?
So all of these were antibiotics. And then
All these are antibiotics, and all these are beta-lactams. So, in your family, you have your dad's side, and that's the penicillins. Then you got your mom's side, those are the cephalosporins, but they're all fusionamines. I'm not saying that right, but and then your sister's kids, her family, that's the carbapenems. Then there's just you. That's the monobacterium. Or your brother's kids. Now you're gonna tell me I'm only child. Yeah, great.
so the penicillins and cephalosporins are also things.
Yeah.
Okay.
Yeah.
Okay.
So it's just bigger rubric. And they all inhibit the cell wall. Synthesis of the cell wall. So they're all bacteria cited. All right. Nikki says it's time for a break. And we'll try to get the rest of these quizzes back to you. So let's take 5 and go ahead and stretch and get a drink and Smoke them if you got them. Whatever.
Dr. B,
Yeah.
the word you used about inhibiting the cell wall, can you spell that? You know what I'm talking about, ends and cycle. Is that
Bactericidal.
bactericidal? So like CIDA. Okay, thank you.
Bactericidal. Is there a basketball game tonight?
Basketball game, is that what you said?
Yeah, basketball game tonight.
No, they will be studying for it now.
Okay. Let's see. I have a basketball game tonight.
Every time you do that, I'm like, I might as well take it.
Not yet. So.
It's just, it's a new fresh. I got one time with the arms waving on that. You know, I hear you. I'm like, go over there. So these were
There's more.
my fingers don't move that fast. I'm like, coordination. I go, This is big one.
I should look at it before I hand it to you. Oh, okay. And wait, we need it more than. Yeah.
Roll yourself. Yeah. Yes, you did. I don't know what you're committing to, but you did. That is actually
Okay.
more. Yeah. Did you? Are you hearing me? Were you in here when she showed me the first time? Yeah. I was in screaming. It like doesn't get less funny. I know. Like I just was not. So when she said fell, I thought maybe she tripped backwards. Oh no! No, like you keep wrong yourself. She tried to call me. No, that was the thing. Oh my God. Yeah. How was your workout? I thought so. I'm used to that. Okay.
No, I don't.
I thought you were
You saw it getting everything done. Okay. Yeah.
That's less funny.
I just want.
I know. This snap. Oh, I had no idea it was a big one. It's actually snack. You see Cassie's. She was
Okay, time to get back in the saddle and ride. Very good. All right, so we talked about the glycopeptides last time. I'm going to leave that since we already worked that over. Remember, these are pretty specific for gram positives. They have virtually no activity against gram negatives. They are bactericidal, but only weakly so. And they tend to be used for methicillin-resistant Staphylococcus aureus. The fluoroquinolones we talked about a little bit. Let's talk about those now. So anybody remember how these affect bacteria? No one remembers? They inhibit DNA gyrase. They inhibit DNA gyrase. What does DNA gyrase do? It supercoils the DNA. So when the organism wants to replicate its DNA, it needs to pull the strands apart. You supercoil DNA, there's a lot of tension there. It takes a lot of energy to pull them apart. So DNA gyrase comes in and says, I'll undo these supercoils. So you can pull those strands apart. Without DNA gyrase, no DNA replication. No DNA replication, no survival. You die. So they're bactericidal. Bactericidal. You'll notice they all have this common ending, floxacin. Floxacin. These come in oral and parenteral, yeah. Yeah, yeah. They have a quinolone ring system, but then they have a fluorine attached to it. That's why they're called fluoroquinolones. These are broad spectrum antibiotics, very broad spectrum. They have very good bioavailability. Most of the time when people take them, they're well tolerated, but as more and more post-marketing research has been done on these drugs, a greater spectrum of side effects have been uncovered that are not very common, but can tend to occur in certain people. So the first, yes. Yes, they come in oral and parenteral preparations. So you can use these at the hospital for someone who is hospitalized, who's very sick. They might not be conscious. They might be intubated, but they need antibiotics. Of the first nursing class I graduated, one of the guys in that class was John Machezik, and John is working now ED at Henry Ford Allegiance. And he said with the COVID patients who have ARDS, the big issue is secondary infections. And so because those secondary infections very often might be polymicrobial, these are the drugs they use very often. So in elderly patients, these drugs can cause hallucinations, confusion, and dizziness. Very rarely does that happen in younger patients, but it's been reported in elderly patients. It's been reported frequently enough so that if you give it to an elderly patient, you need to warn the caregiver that this is a possibility, particularly if they're on some sort of psychopharmaceutical in the first place. 2, they can elongate the QT interval. Maddie, what does that mean? Yes, me. The QT interval, what does that mean? EKG, Q, P, Q, R, S, T. What's P, Q, R, S? What's T? There's P, Q, R, S, T. T is so the Q to T interval. This is atrial depolarization. This is ventricular depolarization. This is ventricular repolarization. The QT interval then is the interval from the beginning of depolarization to the midpoint of repolarization. That means that interval between depolarization and repolarization can be elongated. Now, this typically only happens in people with pre-existing heart conditions. But what if you're giving it to a patient with endocarditis who already has some sort of cardiac issue? Now it becomes an issue. Younger person, probably not an issue. Three, tendon rupture. tendon rupture. Levofloxacin is the biggest offender of this group in that regard. Tendon rupture is common in elderly patients relative to younger patients. It's especially bad if they are also taking steroids. Because what do steroids do to tendons? Thins them out, doesn't it? So it's going to increase the risk of tendon ruptures. 4, they can cause some dermatological sensitivity, some photosensitivity to sun. This tends to be minor, but what if you have someone with very, very, very fair skin? What if Miss Keegan over there comes in with an infection and she gets some levofloxacin? You might have noticed, but she's of a rather light colored hue. It was the red hair that tipped me off. She needs to protect herself from the sun. She's probably going to be more prone to sunburn on the fluoroquinolone. 5, can raise blood sugar levels. This is usually only the case in people who are already diabetic, but who are prone to lots of infections, people with diabetes. So again, you get these low percentage things, but certain populations are more prone to them, so I need to consider them. Finally, contraindicated in pregnancy. Pregnant women should not take fluoroquinolones. Never, never, nope, 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 no way, no how. They interfere with bone, joint, and tendon development. Now, what else did we say about fluoroquinolones and how you take them? Anybody remember? Oh, bless you, dear girl. Exactly right. Don't take them with calcium or antacids. You can take them with food, but don't take them with dairy. Take them with some graham crackers, ginger snaps, or something like that. But don't go take it with a big glass of milk. That will interfere with their bioavailability. Now, these drugs are renally cleared. So what are you going to do to a patient with renal problems? You're going to dose them down because the drug now has a longer half-life. So you adjust for renal function. Now there's an upside to this. They're very good for UTIs. But there's an exception, and that is moxifloxacin. Moxifloxacin is not cleared renally. Yes.
Why is that? Like, what's so different about
But moxifloxacin is a substrate for cytochrome P450 1A1 that converts it into a metabolite that is very soluble in bile. So it's excreted out the GI tract. That's far more information on that drug than you ever wanted to know, probably. But hey, that was free. You're getting your money's worth. All right, let's, are there any questions about fluoroquinolones? Let's now go to protein synthesis inhibitors. Let's start with the aminoglycosides. Aminoglycosides, first thing you need to know, they're toxic. So usually they're used topically. If you do use them, the one you usually use is gentamicin. gentamicin is the one that's the least toxic of the yeah, protein synthesis inhibitors, yeah. Protein synthesis inhibitors usually are not bactericidal, they're bacteriostatic. So they stop bacterial growth, but they don't kill the cell. They stop bacterial growth, but they don't kill the cell. The immune system, however, can handle a bacterium sitting like a bump on a log quite effectively. So most of, yeah.
So if it doesn't kill it, is there a chance, like, is it staying dormant?
Yeah. Yeah, oh yeah, sure. That's one of the risks of drugs like this. But usually, if you don't make protein, you can't make things that code for resistance or something like that. You're just stuck. So you get washed out or you get destroyed, or the destruction then usually has to be by some other means. But a cell that's not growing is a cell that is very susceptible to being killed off by other means. Right. So neomycin is used in neosporin. Neomycin just used topically. Streptomycin is only used to treat plague. What organism causes plague? That one, Yersinia pestis. If you are stuck, you have nothing else to treat it, streptomycin is effective against Yersinia pestis. That's your last resort, though. All right, so these drugs, a lot of their toxicities are dose related. So you don't want them to accumulate. So the biggie is nephrotoxicity. This nephrotoxicity is dose related. If you properly dose the drug and don't give it with anything else that's hard on the kidneys, you can usually get away with it. The issue comes if you have a patient with compromised renal failure in the first place, or they're also getting something else that's hard on the kidneys, it's going to do their kidneys in. So nephrotoxicity is the biggie. The other is ototoxicity. Ototoxicity. Also dose related. So you're going to monitor patients for hearing loss. How are you going to do that? Grace, how are you going to do that? Yeah, what is it? Yeah, you rub the tragus and you whisper in one ear, you whisper baseball or hot dogs or elephant or tiramisu or whatever. And you say, well, what do they say? And if they may get it, elephant, you said element. Okay, we're getting pretty close. If they baseball. Oh, you said my daughter's first name. And no. Okay, you're making that up. You didn't hear me, did you? That's essentially, if you start to see a decline in hearing, you pull the drug. Those tests are easy. They're low tech, they're easy. Anyone can perform them who knows what they're doing. I got to monitor renal function. Very good. Fluid output, urine output, good. If you give them at high doses, they can also cause nerve blocks, and they can cause paralysis, therapeutic paralysis. Now, aminoglycosides are active against gram-negative bacteria. Very poor coverage of gram-positives. Also, these hit gram. Also, the uptake of aminoglycosides is oxygen dependent. So these drugs cannot be used for anaerobes, only for aerobes. Sometimes you can treat, someone with a antibiotic that hits a cell wall and a protein synthesis inhibitor. The strategy for that is that the enzymes that make the cell wall are proteins. Therefore, if you inhibit protein synthesis, the cell wall gets thin. And the cell wall, therefore, gets easier to inhibit. And so these two drugs synergize together. And that is done sometimes also. If you have cells that are making toxins, many of those toxins are proteins. You give a protein synthesis inhibitor, you will inhibit toxin production. So for toxic shock syndrome, for example, very often you give a protein synthesis inhibitor plus a cell wall inhibitor, because that inhibits production of the toxin and kills the bacteria. So that's a strategy you can use. But aminoglycosides and penicillins, if you put them together in an IV bag, they react with each other and they do this. They look like cats that have lost all their hair. They react with each other and they destroy each other. So if you give them IV, you give them separate lines. You don't mix them ever. So just think of two cats fighting and fur is flying, and then you have two hairless cats. Aminoglycosides and penicillins, in particular, beta-lactams, if you get them together, you give them separate lines. You don't put them in the same bag, don't put them in the same line. They will chemically react with each other. Oh yeah, Tobrex is used ocularly. Tobrex is used on the eye, and its systemic absorption is minor, so it's not really much consequence. That's a good drug to use for pink eye and for blepharitis and stuff like that. That's the other aminoglycoside I did not mention. Tobramycin. Yeah. All righty. If you put someone on aminoglycoside, it's a good idea to check drug levels in the blood. That way you'll know if you're at toxic levels. Also, aminoglycosides their volume of distribution is very good in some organs, terrible in others. So for example, they don't get distributed to the lungs very well. So they're not very good for URIs or respiratory infections in general. All right, questions about these folks here? Good. Yeah. All right, let's talk about tetracyclines. These also are protein synthesis inhibitors. These also are bacteriostatic. These are the drugs of choice for tick-borne diseases. So for all tick-borne diseases, these are the drugs of choice. Who can I pick on this time? Karis, can you name a tick-borne disease for me, please? Just one. A tick-borne disease.
So like Lyme disease?
Lyme disease, that's tick-borne, absolutely. Clarissa, can you name another tick-borne disease? Emily can't help herself over here. Yes? Oh, yeah.
Sorry. It's not me, but so it's like Lyme disease and infection?
Yeah.
Because I don't know, I thought it was like a virus.
No, it's a spirochete, Borrelia burgdorferi.
So the antibiotic just kills
The antibiotic kills the spirochete, yeah. Come up with one yet, Clarissa? How about Rocky Mountain spotted fever? The tick-borne? Yep. But you didn't say typhus, and that's good because that's louse-borne. That's louse-borne. Okay, so it's good for tick-borne diseases. It's good for spirochetes, like in the case of Lyme disease. Also pretty good for streptococcus, staphylococcus. Not terribly good for gram-negative rods. Not terribly good for anaerobes. So this would include doxycycline and minocycline. And we introduce you to that new drug, minocycline, last time. And these are available mainly orally. There is a parenteral version of this one. I don't think there's a parenteral version of doxycycline. If somebody discovers one and proves me wrong, I'm all ears, but I don't think there is one. There is, however, a tetracycline that is a off the beaten path member of the kind of black sheep of this group that is parenteral, and that is tigacycline. Tigacycline. That is parenteral. No, tigacycline is only parenteral. Minocycline comes both oral and parenteral. These, I'm almost, well, minocycline comes in a topical form, comes in foams, in topical forms for acne. Doxycycline is largely oral. I don't think there's a topical doxycycline. I don't think there is. I don't think there is. I might be wrong, but I don't think there is. Yes.
Sorry, back to the Lyme disease thing. So will that like totally get rid of it? Because I know lots of people have like they struggle to control it and ever get rid of it. So will that like totally?
That's probably the immune response
Oh,
against the
okay.
disease. Spirochetes in general, most of the damage is not the organism themselves, it's immune response against the organisms.
Okay, and that's what takes so long to.
Yeah, yeah. That's what can cause the sequelae a long time. People can have these and not have any organisms in the body at all. There's stuff on the web that, chronic Lyme disease, you're not gonna get rid of the organism. Yeah, you did.
You're just having.
It's your immune response that's still taking a whack at your tissues. So, yeah. Syphilis is the same way. Syphilis, you have syphilis for a long period of time and you get rid of it, you can still have conditions that are largely due to the immune response against the spirochetes. Okay. Tetracycline is very good against so-called atypicals. Atypicals. We talked about these last semester. Anybody remember what an atypical is? Paige, remember what an atypical is? You don't? Abby, you remember? Andrea? No? Sydney? Anybody? Getting a review of micro here. This is good. So mycoplasma don't have a cell wall. So they are atypical. They're atypical because you can't culture them. Well, you can, but you have to use special media to culture them. Also, Legionella. Legionella, you need special media to grow it. You just try and grow it on blood agar, won't grow. You have to use special media, so you culture and it doesn't grow, it's an atypical. It's an atypical. They're also not susceptible to many of the common antibiotics. So Legionella, not susceptible to beta-lactam antibiotics. Has peptidic glycan, but it's just resistant to beta-lactams. Mycoplasma just doesn't have a cell wall. So because it has no cell wall, it's not susceptible to beta-lactams. It's an atypical. This drug is extremely effective against atypicals. Now, the other thing this drug is very good for is MRSA. MRSA, so vancomycin resistant Staph aureus, it's also good against vancomycin resistant enterococcus. So this is a good drug when the chips are down and the horizon seems dark and you tried most of your stuff and it's just not working. This is one to which you can turn. And it may very well work. There's no activity against Pseudomonas. There's no activity against Proteus. Okay, let's talk AEs for tetracycline. We hit on those last time. Many of you hit on those. First of all, it can upset your stomach. You can take them with food. Just don't take them with dairy. Don't take them with dairy or iron or calcium or antacids or multivitamins. They will disrupt their absorption. The oral drugs, if you take them properly, have bioavailabilities pert near 100%. So they're very, very well absorbed. Now, these drugs will cause photosensitivity. So use sunscreen. They do cause GI disturbances. That tends to go away if you're taking food. Interestingly, this drug, tetracycline, is given intravenously, but it still causes vomiting. Minocycline has been reported to cause dizziness and vertigo. There was a report I saw that contested that. So this causes vertigo, but it probably isn't causing as much vertigo as some of the reports say. Other issue with these drugs, you don't take them if you're pregnant. And you don't use them in children younger than 8 years old. They will discolor teeth and they will cause banding of the bones. So pregnancy, survey says, younger than 8 years old, survey says. And if you have skin like Keegan's, Keegan, you're gonna wear sunscreen. Thank you. Sunscreen. Oh, good golly, this takes longer than I think it should. All right, we'll pick this up on Wednesday. I have 2 tennis players who won't be here on Wednesday. Anyone else won't be here on Wednesday? You'll be here? Very good then. I will see you on Wednesday.
Hey, Dr. D,
Yes, ma'am.
did you put up those examples for the presentations?
Put up what?
The example videos from last